Good evening. Welcome to our Women's Health and HHT Across the Lifespan with Dr. Jenny Zhou. We're very excited to have everyone here this evening. We're going to go through a little bit of housekeeping, and then we're going to get on to our webinar. Just a couple HHT, Cure HHT projects and different activities that are available to our patients and our community. We have our HHT Connect, our global HHT patient registry is available. You can get more information on our website, and this is the link as well. We also have other research opportunities that are available, so you can check all those out and all the details. Again, all of that information is housed on the Cure HHT website. We're only a few short days away from Awareness Month, which is exciting. We have a lot of great activities and webinars and other activities planned for our community. We hope you'll join us and think about ways that you can spread awareness about this disease. Our first event is going to be our Ask Me Anything with Dr. Miles Conrad from the University of California, San Francisco. That's going to be fun. He's hosting that on Tuesday, June 2nd from 7 to 8. And again, ask him anything, and that'll be a lot of fun. He did this last year, and it was very well received. On Tuesday, June 16th, we have our town hall with Tanya Compitello. She's our Senior Director of National Healthcare Programs for Cure HHT. She's going to be talking about all of our centers of excellence, our program updates, our newest centers, and all of the different centers across North America. So she'll be giving us a lot of insight about that. So that's going to be really exciting. And then on Awareness Day, June 23rd, our CEO, Marianne Clancy, will be hosting our Cure HHT What's New and What's Happening. And that'll be really exciting. She'll be talking about the ways that the foundation is moving forward with research and initiatives. And so you don't want to miss that. It's going to be a great day and a lot of sharing. Just a couple of housekeeping. If you have any questions that you want to pose to Dr. Zhou, please put them in the chat, and so that we can interact, and keep your questions general in nature so that she can answer those for everyone. This presentation will be recorded for the evening. So I'd like to move forward and introduce you to Dr. Zhou. Thank you so much for joining us tonight. Just give you a little bit of Dr. Zhou's background. She is a hematologist and assistant professor of medicine at the University of California, San Diego, Center for Bleeding and Clotting Disorders. She has a special interest in patients with inherited bleeding disorders, notably HHT, and she's the director of our HHT Center at the University of California, San Diego. Her clinical and academic work focuses on women's health in bleeding disorders, and she leads a multidisciplinary clinic in collaboration with gynecology to optimize care for these patients. And I did want to just send a quick shout out that we have patients attending this evening from all around the world: Argentina, Australia, Japan, Mexico, New Zealand, the Philippines, South Africa, China, Great Britain, Brazil, Canada, Finland, Portugal, and Switzerland. So welcome everyone. And of course, the United States. We're really happy to have you. And I'm going to turn everything over now to Dr. Zhou.
Thank you so much, Phyllis. And thank you, Cure HHT, for the invitation to speak on this very important topic. So I'm just going to get my slideshow ready. Okay, there we go. So today I want to discuss women's health, a broad overview of women's health issues in HHT across the lifespan. So the main topics will be on iron deficiency, anemia, and menstrual health, pregnancy planning and management, and then hormones in HHT. What do we know about how they modulate nosebleeds, hormonal therapies in reproductive years, menopause, and hormone replacement therapy? So, why is this topic so important? We know that women's health affects half the world's population, yet major gaps still exist in research, funding, evaluation, and treatment for women and women-specific conditions. There have been several studies that have looked into this. One showed that across 21 years, women were diagnosed later than men for more than 700 diseases, and sometimes on the order of years later. Another study showed that women spend 25% more time in poor health relative to men, and almost half of the health burden affects women of working age, signifying that these have implications beyond just physical health. And we know that men and women's health are not equal. There are unique considerations in women that include reproductive and gynecologic health, pregnancy and postpartum, and menopause and hormonal health. This was a great opinion piece by some maternal fetal medicine specialists that was recently published. And I think the title aptly captures the disparity in current times. Until women's health is everywhere, women's health is nowhere. And this is highlighted by how a recent report showed that spending on women's health research in the past decade averaged 8.8% of the NIH total budget. Specific to HHT, there have been a few studies that have looked at various things in women's health. So one was a study that evaluated if women with HHT had different disease manifestations than men. And so in this study of over 100 women with HHT, women seem to have more severe liver involvement, lung AVMs, and needed invasive procedures more frequently. They also scored higher on the simple clinical scoring index, suggesting a higher severity of disease. There were no significant differences in epistaxis severity, anemia, hospital admissions, or mortality. Another study found that gender differences in HHT clinical trial enrollment was more pronounced with more male enrollment in earlier clinical trials before 2000, which has fortunately balanced over time. HHT may also be the most morbid inherited bleeding disorder in women. So this was a study that was published in 2024 that compared 100 women with HHT to 100 women with von Willebrand disease, which is the most common inherited bleeding disorder. And HHT women uniformly had significantly higher odds of iron deficiency anemia, requiring iron infusions on the order of 17-fold, red blood cell transfusion requirements, and hospital admissions on the order of 14-fold compared to von Willebrand disease women. So overall, significantly higher disease-related complications and overall healthcare utilization. So let's get into iron deficiency anemia. This is still an issue that is highly prevalent and remains underdiagnosed and undertreated in patients with HHT and disproportionately affects women. There was a publication on over 10,500 women with various types of bleeding disorders, and it showed that 72% had iron deficiency. So this just emphasizes the high incidence of iron deficiency in those with chronic bleeding. In HHT, the prevalence of iron deficiency and or anemia is estimated to be about 68%, with almost half of patients requiring iron infusions. In women with HHT, 66% were found to have iron deficiency anemia. We know that iron on a cellular level is important for hemoglobin synthesis and the metabolism of virtually all cells. And so iron deficiency anemia has wide-ranging multi-organ complications if not treated. And specific to women, this also includes gynecologic pregnancy complications such as preterm labor, low birth rate, fetal growth restriction, impaired fetal development, preeclampsia, and postpartum hemorrhage. So this question comes up a lot. So I saw one of my HHT patients initially had these lab findings. Her ferritin or iron stores were 35. And so this question comes up in that, doctors say that I don't need iron replacement because my ferritin is showing within the normal lab reference range. So my answer to that is that there's good emerging evidence and consensus that a ferritin of less than 50 reflects a more physiologic threshold for iron deficiency. These laboratory-based reference ranges for ferritin are different for men and women, which really has no physiologic rationale behind that. The ranges are derived from 95% of the sample population, and given that up to 30 to 50% of women have iron deficiency, deriving a cutoff at the lowest 2.5% is going to vastly underdiagnose iron deficiency. And so to that point, iron deficiency can also be overlooked if the hemoglobin is normal. We know that non-anemic iron deficiency can also cause symptoms and complications because anemia or low hemoglobin is an end-stage complication of iron deficiency. There's been numerous studies that have shown the indication in treating non-anemic iron deficiency. It's improved patients' aerobic capacity, cognitive function, fatigue, etc. So for all HHT women and patients, everyone should be screened with a complete blood cell count and iron studies. We use a ferritin cutoff of less than 50 rather than the lab reference range. And then in terms of management, oral iron could be considered in mild cases. However, the vast majority will require iron infusions. So overall, iron deficiency anemia in women with HHT is driven by multiple cumulative and also life stage dependent factors. Hello? Sorry. Can you guys still see my slides? Okay. So let me share my screen. I think the connection stopped. Sorry about that. Okay. How about right now? Okay, perfect. Sorry about that. I think the connection dropped somehow. Um, So not only are there HH related bleeding sources that contribute to iron deficiency anemia in women, such as recurrent nosebleeds and GI AVMs, and generally these worsen with age, but also women-specific factors that add to the additional iron burden, such as menstrual blood loss during the reproductive years, and then during pregnancy, which is a period of increased iron demand. And so all of this can cause a cumulative iron deficit over the lifespan, resulting in earlier onset and greater lifetime severity of iron deficiency anemia in women with HHT. And so this is why it's critical to screen early and manage appropriately. So going into menstrual blood loss and menstrual health and how this all ties into. So we know that in very simple terms, our menstrual cycle is essentially a sequence of events from communication from our brain to ovary to uterus. Every month, the uterine lining thickens in preparation for a possible pregnancy. And if that does not occur, it sheds, and that's when the menstrual bleeding occurs. And then hormones such as estrogen and progesterone also play a key role in this. So we know that in premenopausal women, menstrual blood loss is a strong independent determinant of iron deficiency and anemia. So this was a study of almost 500 women who were blood donors. And what they found was that menstrual blood loss, as determined by this PBAC score, had a linear correlation with iron stores or ferritin and hemoglobin level, meaning that the higher the PBA score or more menstrual blood loss, the lower the ferritin and the lower the hemoglobin. So how does this relate at all to HHT? So this question also has come up before. I've always had heavy periods. Could this be related to my HHT? So what do we know about heavy menstrual bleeding and HHT? So first of all, what is heavy menstrual bleeding? Heavy menstrual bleeding is defined by excessive prolonged menstrual blood loss that interferes with a person's physical, emotional, social, or material quality of life, or menstrual blood loss of 80 milliliters or greater. It's estimated that 1 in 4 to 1 in 5 women have heavy menstrual bleeding in the general population. In a survey of over 600 women with HHT, heavy menstrual bleeding was reported in up to 74% of women. In the study I mentioned earlier that looked at women with HHT compared to women with von Willebrand disease, 35% of women with HHT had heavy menstrual bleeding compared to 63% of women with von Willebrand. And then in the Chorus registry, which is the first registry for HHT, again, 35% of women were found to have heavy menstrual bleeding, with 41% requiring treatment. How do we diagnose heavy menstrual bleeding? So the gold standard historical way has been through the alkaline hematin method. And so this is a way where patients have to store and collect essentially all their used pads during the menstrual cycle, send it to a specialized lab where they soak it in a chemical solution and extract hemoglobin to try to estimate the amount of blood loss. And then there's been, many different patient-reported surveys and questionnaires developed. The most well-known is the PBAC, which is a semi-quantitative assessment, as shown here. However, there are limitations with each of these methods. So the alkaline hematin method is impractical, labor-intensive, really only available in research settings, and the PBAC is very subjective too. And so more recent studies have actually shown that the sensitivity and specificity of this to detect heavy menstrual bleeding is quite a bit lower than historically thought. What are the causes of heavy menstrual bleeding? So all that to say is that there's not a great method to objectively diagnose heavy menstrual bleeding now. So we take into account patient-reported symptoms. We use some of those surveys. And then also laboratory parameters as well, obviously signs of iron deficiency, anemia. And when we evaluate potential, factors that cause heavy menstrual bleeding, this is an acronym that was developed by, gynecologist Palm Cohen. And so it lists all the potential etiologies that can cause heavy menstrual bleeding, from structural causes such as polyps, fibroids, rarely cancer, to non-structural causes such as bleeding disorders, hormonal issues, and sometimes not otherwise specified. So in HHT, it's really unknown what the contributions could be for heavy menstrual bleeding. Is there structural components such as uterine AVMs? And then also, are there also non-structural factors such as iron deficiency anemia? And I'll get into those in the following slides. So regarding structural, what do we know about uterine or pelvic AVMs? So there's really less than a handful of cases of uterine AVMs reported in HHT women. I think I found maybe 2 or 3 in the literature. So the prevalence is really unknown in HHT. The prevalence of uterine AVMs in the general population is estimated to be about 3 to 4%. And typically these are in the setting of some type of gynecologic procedure or surgery, such as a DNC or therapeutic abortion, or uterine surgery or uterine trauma. There was a case series of 21 women who had symptomatic uterine AVMs. One of them was thought to be congenitally related, so potentially HHT. And so how we diagnose this is with a pelvic ultrasound with the colored Doppler or flow, and then sometimes with the MRI of the pelvis. The treatment that's been described more frequently has been uterine artery embolization, which is a minimally invasive procedure which basically blocks off flow to the uterine AVM. And then there's some few reports about using potential hormonal therapies as well. So largely in HHT, we don't know a lot about uterine AVMs. We don't know how frequently they do occur, their association with heavy menstrual bleeding, and then also we don't know the hormonal influences on these as well. So this is just an example of one of the case reports of a patient with a uterine AVM diagnosed by this Doppler ultrasound. So you can see this tangle of vessels with this color mosaicism, which basically signifies high flow. And then on the right is the uterine artery embolization. On the top, you can see this tangle of vessels. And then after embolization, you have complete obliteration of that AVM. And so are there potential non-structural contributions that also could factor into heavy menstrual bleeding and HHT? So there is emerging evidence that iron deficiency anemia may actually worsen bleeding as well. This has primarily been studied in surgical and trauma settings where pre-existing anemia was associated with higher risk of operative bleeding, poor outcomes, and increased mortality. And also in postpartum hemorrhage or bleeding after a delivery, prenatal anemia was also an independent risk factor for that. So the the etiology of this is not well understood. Presumably, if someone is iron deficient anemic, they have less physiologic reserve for bleeding, but also there is some evidence that the blood being less viscous or thick, there could be some impairment of platelet margination. And so overall, it's possible that patients with iron deficiency anemia form these less dense, porous, fibrin blood clots, unlike, someone who does not have iron deficiency anemia. And so this could contribute to increased bleeding tendencies as well. In terms of management of heavy menstrual bleeding, it's primarily a collaboration between hematology and gynecology. There's many different hormonal therapies that come in many different flavors, many different routes of administration, as shown in the picture here. We have combined estrogen progesterone methods, progestin-only methods. And so it really depends on what contributing factors are thought to be contributing to the heavy menstrual bleeding, and then a discussion on which of these might be the most effective. There's also non-hormonal medications such as tranexamic acid pills, which I think many of you are familiar with because we also use it for nosebleeds. There have been studies that have shown that tranexamic acid taken on the first heaviest days of a period can reduce the menstrual blood loss by 40 to 60%. So that's something that can be also helpful in this context. And then depending on if there's any anatomical factors as well, there could be procedural or surgical interventions. So overall, what we know about heavy menstrual bleeding HHT is really only the tip of the iceberg. What we know is that heavy menstrual bleeding seems to be reported more frequently in women with HHT than in women without HHT. And we know that iron deficiency anemia are also more common. But however, a lot remains unknown. We don't know the true prevalence. We don't know the mechanisms and pathophysiology of it. We don't know how uterine AVMs, how prevalent they are, and how that comes into play. We don't know the impact on quality of life, fertility, pregnancy outcomes, and there's a lot that still needs to be learned about this. So the next topic that I'll go into is pregnancy planning and management. So this is a patient question. My partner and I are considering trying to have a baby in the next year. What complications could I have because of my HHT? So what is recommended in terms of pregnancy planning and management? So in very general terms, we know that HHT is a genetic condition of autosomal dominant inheritance, meaning that all children have a 50% chance of inheriting the mutated gene and being affected. So there's various types of genetic testing that can be done. And one is pre-implantation testing. So this is before, a woman would become pregnant. And this is screening or testing embryos that are created through in vitro fertilization for the known family gene mutation. And so this is a way then, if desired, to select embryos that do not carry the gene and go through IVF. And then there's methods for post-conception testing. So these would be done during pregnancy. something such as chorionic villus sampling, which is taking a biopsy or sample of the placental tissue, typically done at 10 to 12 weeks gestation, or amniocentesis, taking some of the amniotic fluid, typically done at 15 to 18 weeks. However, these are invasive procedures. There is, very small risk of bleeding and miscarriage associated with these. And so really, the indication for these would be if it is going to affect carrying the pregnancy through term or not. And if there is no consideration for changing course or considering, a pregnancy termination, then really these would not be indicated unless there are other reasons. And then finally, there's postnatal testing, which you can do genetic testing on the umbilical cord blood of the infant right at the time of delivery, or genetic testing later in the infant or child with their pediatrician. So what about pregnancy outcomes in HHT? What do we know about that? There's been several studies that have looked into that, and I've just highlighted a few of them. But essentially, most of these were retrospective, so looking back at pregnancies. And what they found was that for the most part, the rate of a serious complication was pretty low. So for example, in the first study, 1% of pregnancies resulted in a major pulmonary AVM or lung AVM bleed. And then there was a 1% risk of stroke, 1% of maternal death. What that study did show was that for any of these serious life-threatening events, a prior awareness of HHT or lung AVMs was associated with improved survival. Another survey of over 500 pregnancies showed that there did not seem to be increased risk for birth defects, uterine bleeding, preeclampsia, placental abnormalities, low birth rate, C-section rates, or infertility compared to rates in the general population. And then also, most of the serious complications seem to occur in the second and third trimesters. And in the third study, the rate of major complications in pregnant women with HHT was 13%. And all of these occurred in women who did not have screening for lung AVMs. So this just emphasizes the importance of appropriate screening during pregnancy. And then finally, there was a more recent publication that looked at, information from deliveries across a decade in over 600 patients. And they found that HHT patients did have were more likely to have severe maternal morbidity compared to those without HHT. There were higher rates of preterm birth, C-section, and cerebrovascular complications found in this study. This literature review of over 1,500 pregnancies showed that overall the maternal death rate in pregnancy was about 1%, and the rate of severe maternal complications in an HHT woman is around 2 to 6.8%. And these occur again in non-diagnosed or non-screened HHT patients. These complications are listed by the organ system. So for the lungs, that might be, a rupture of a lung AVM, coughing up blood, and then brain AVMs, and then liver AVM complications are shown there too. So the overall message is that early education, appropriate screening reduces the risk of complications. And for many women, multidisciplinary care at a specialized center is recommended. In terms of screening, there are guidelines published by the Second International HHT Expert Guidelines, which very clearly state the screening recommendations. So what they say regarding brain AVMs is that for pregnant women who do have clinical symptoms that are suggestive for brain AVMs, they should undergo an MRI without contrast in the second trimester. Asymptomatic patients do not require an MRI just because they are pregnant. And this is because the rate of a brain AVM bleed in pregnancy is similar to non-pregnant HHT patients, and it's very low at 0.4 to 1% per year. In terms of an epidural, the expert panel recommends not withholding an epidural solely because of a diagnosis of HHT, and that screening for for spinal AVMs is not required. And this is because there's no published reported cases to date of HHT patients who have developed complications or bleeding from a spinal AVM from the epidural. Firstly, the rate of spinal AVMs in HHT is very, very rare, so 0.5%, slightly higher in children. And most of the spinal AVMs are located in the subarachnoid space, which the epidural needle does not enter. And also, most of them are located in the thoracic spine, which is much higher up than where the epidural is placed. So for these reasons, the expert guidelines do not favor the necessity of screening for spinal AVMs for epidural. I know that it can vary by institutions. In some places, the anesthesiologist may not be comfortable with that. And so I think that's where the multidisciplinary discussion comes into play. Regarding lung AVMs, the guidelines say that for all patients regardless of symptoms, lung AVM screening should be performed if not done so recently. And this should be either done with an echo with bubble study or a low dose non-contrast CT chest, depending on what is available at the institution. And a CT chest, if performed, should be done early in the second trimester. In patients who are symptomatic with lung AVMs, they should get the non-contrast CT chest at that time and then treated for their lung AVMs following general treatment guidelines for non-pregnant HHT patients. And so why is this important? So we know that especially during the second trimester and third trimester, there are physiologic changes in pregnancy that can really impact lung AVMs. So one, the output by the heart will increase by 30 to 50%. The blood volume in the women will increase also by 40%. There'll be high levels of progesterone, which make the veins more distensible and stretchy. And so all of this can result in enlargement, increased blood flow through those lung AVMs and potential rupture. So the risk of complications from lung AVMs during pregnancy is about 17% overall. These are non-fatal complications. And in terms of mortality, it's about 2%. So what are these reported complications? We've discussed this already: rupture of the lung AVM causing hemothorax, coughing up blood, stroke, etc. So in terms of considerations for the mode of delivery, expert guidelines say that women with non-high-risk brain AVMs can proceed with a vaginal delivery. However, they may require assistance second stage on a case-by-case basis. For those with high-risk brain AVMs, then a C-section is oftentimes preferred. There's been no reports of pregnant HHT women having a brain AVM bleed during labor. And in the studies that I mentioned, including other studies, the approximate rates of vaginal delivery in HHT women are around 60 to 80%, and cesarean delivery around 20 to 40%. So it's in terms of the mode of delivery, it's a very individualized discussion, with the multidisciplinary team. But in general, there's no absolute contraindication to, vaginal delivery in HHT patients, but there are special considerations, in select cases, and also if there's other medical conditions or gynecological factors that would sway, the choice from one to the other. And then lastly, I just also wanted to highlight the importance of optimizing iron deficiency in pregnancy. As I mentioned earlier, pregnancy is a very high iron demand state, and this is likely, more intensified in HHT women due to one study showing that over half of HHT women reported worsening nosebleeds during pregnancy. And so I like this picture because it shows how much the iron requirements substantially rise by each trimester. So you can see in the third trimester, especially, there's a very high increase in iron requirements, not only for maternal red blood cell production, but also fetal growth. And so this is why iron studies should be closely monitored and treated early during pregnancy. And then, so the last section that I'll discuss is hormones and HHT. So one question that also comes up is that some people notice that, my nosebleeds appear to have a cyclic pattern and are worse a few days before I start my period. So what do we know about hormonal modulation of bleeding and HHT across the lifespan? So in this illustration, you can see typical hormone fluctuations, estrogen, progesterone throughout the lifespan of a woman. And obviously, will increase through puberty, have up and downs during reproductive years, high during pregnancy, and then gradually start to decline during perimenopause, and then become at low levels during menopause. And then if women take postmenopausal hormonal therapy, then obviously the levels will be higher. So focusing first on the reproductive years, we really don't know much about how menstrual cycles are associated with nosebleeds. But, thinking about the hormonal fluctuations during a menstrual cycle, we know that during the first few days or the few days before bleeding starts, that's when estrogen and progesterone are typically at the lowest. And so there have been very limited reports of women noticing, increased nosebleeds during this period. And perhaps this is related to the low levels of estrogen. This was a electronic questionnaire survey of over 300 women with HHT and seeing how different questions evaluating if there's any association with different stages of their life and nosebleeds. So as you can see in the figure here, what's interesting is that 43% of women did feel like their nosebleeds were worse during their menstrual periods. And then in menopause, the majority, 60%, did feel like their nosebleeds worsened as well. In addition, 70% of women did report taking hormonal therapy. 52% who took combined estrogen and progesterone felt that they did have less nosebleeds on that. And then 1/3 of women also stated their bleeding worsened during pregnancy. So this kind of ties into our next discussion point, is that I heard that taking estrogen birth control will help with nosebleeds. So what do studies show about efficacy of hormonal therapy for nosebleeds and HHT? So worldwide, hundreds of millions of women use exogenous hormones as contraceptives for managing their periods or for postmenopausal hormonal therapy. And 40% of women have used, oral contraceptives at any one time. 40% of postmenopausal women have also been on hormonal therapy. Since the 1950s, there's been interest in evaluating if hormonal therapy is effective for reducing nosebleeds and HHT. And this has come up in different, types. So why is this? Because there is evidence that estrogen has some effects on blood vessels. So what is found is that estrogen can induce squamous metaplasia, thereby stabilizing the epithelium. So what does this mean? So as shown here, it's believed that estrogen could potentially thicken the lining of blood vessels so they're not as prone to bleeding. We also know that estrogen can increase pro-blood clotting factors, and so that potentially could help offset bleeding in some degree. There's been limited studies that have shown that a subgroup of HHT patients could have estrogen receptors expression in their nasal mucosa, but then other studies have not really shown that as well. So one of the earlier studies looked at 12 HHT patients that were treated with estrogen ointment intranasally twice daily for 12 months. And what they saw on histology was that there were changes in the nasal surface mucosa at 6 months. And then at 12 months, as shown in this picture, it seemed like the former lining, now you have this thick keratinized lining on top of that blood vessel from the intranasal estrogen therapy. So this kind of brought forth interest in these studies on estrogen and nosebleeds and HHT. A lot of these studies were done in the 1970s and 1980s, and there was a lot of, there was some positive results. There were, a wide range in doses and types of estrogen and also other confounding factors. The only randomized control study on oral estrogen was in 1981, and that was in 31 patients treated for 3 months. And that one did not show that there was any significant improvement in nosebleeds with oral estrogen. And then there's been another study looking at the estrogen spray, the twice daily estrogen spray, and also looked at other types of nasal sprays, including bevacizumab or tranexamic acid compared to placebo. And in that study, there was no differences either in any of those drug therapy groups compared to placebo. However, there have been small reports, such as the last study listed, where there have been significant improvements in epistaxis severity from this intranasal estrogen ointment. And then there's also been another group of hormonal therapy that has been studied to some extent in HHT, and these are selective estrogen receptor modulators. Things such as tamoxifen, which you may have heard of, typically used in breast cancer. And these agents have anti-estrogen effects in certain tissues, such as the breast, but then they have pro-estrogen effects in other tissues. And so, randomized control trial of tamoxifen daily compared to placebo for 6 months did show an improvement in nosebleed frequency and severity. And then the long-term follow-up on that study showed that it was pretty well tolerated. It can cause, hot flashes and vaginal dryness. And so that's something to consider, and can also increase the risk of blood clots to some extent as well. And then there's also been newer generation selective estrogen receptor modulators studied as well in these, in the last two studies listed. So overall, the conclusion is that, all these hormonal therapy studies in HHT, these are small, very variable studies, and there's not any consistent results between them. Of course, there's a lot of confounding factors too. But there's no large controlled trials that have shown clear efficacy, and there's the side effect profile to consider as well. So in general, I would say that, these are not first-line agents for the purpose solely of nosebleeds, but if there are other reasons for oral contraceptives, for example, in reproductive women, and they don't have any prohibitive risk factors, then that certainly can be a reasonable option. And postmenopausal women, there's really no data on the usefulness of hormone replacement therapy for nosebleeds, because the estrogen used in HRT is significantly lower than the estrogen that is used in oral contraceptive. But there seems to be some limited data for those selective estrogen receptor modulators that I mentioned, such as tamoxifen. The second, international HHT guidelines do not state hormonal therapy as one of their recommendations for nosebleeds. They state, tranexamic acid or systemic anti-angiogenic agents. And so I think this highlights how the field is moving away from hormonal therapy solely for the purpose of treating nosebleeds into our newer, anti-angiogenic and targeted therapies, including novel emerging agents coming out in clinical trial. And then finally, the last few slides, last few minutes, I'll talk about hormone replacement therapy, since this is a hot topic. So there was this well-known women's initiative study in 2002 that was published, and that suggested that hormone replacement therapy might be associated with increased risk of stroke, cardiovascular complications, breast cancer. And so this got a lot of media attention. And then after that study was published, the FDA had a black box warning on hormone replacement therapy. The use of it then dropped substantially from 27% to 5% from 1999 to 2020. However, with reanalysis of the WHI study and newer studies showing that this is a lot more nuanced than just a dangerous effect. Recently, the FDA removed menopause hormone therapy black box warnings. This was as of November of last year. So this table just states the broad classes of hormone replacement therapy. So it can be oral, it can be transdermal, which is like a patch. It can become in a gel, spray, or vaginal form. So in general, the oral form is more associated with increased risk of blood clots. The transdermal or patch form, because it bypasses liver metabolism, it's been shown that it does not increase the risk of blood clots at standard doses. And then the vaginal form of HRT is really only effective for vaginal dryness or urinary symptoms. So it's not going to be as effective if you have vasomotor symptoms such as hot flashes or night sweats, and there's very minimal systemic absorption. So the decision on HRT therapy is really very, very individualized, and it's a consideration of what are the benefits, what are the main symptoms that you're trying to treat, and then what are the risk profile in that individual person. And so, as I mentioned, some of the risks are stroke, but typically this is in patients who are older than 60, or if it started 10 years from menopause, blood clots, and then breast cancer with estrogen and progesterone, which is duration dependent. And then there's also a new class of non-hormonal therapies for vasomotor symptoms. These are neurokinin 3 receptor antagonists. So this could be a potential option for patients who want to avoid any type of hormonal replacement. Overall, however, there's no specific HRT that's contraindicated in HHT patients. And it's really, again, a specific, an individualized discussion. So what are considerations of HRT in HHT? Well, as I mentioned earlier, if we're using it primarily for nosebleeds, there's no data on if it's going to be helpful for nosebleeds because all the data on estrogen for nosebleeds was the estrogen that's used in oral contraceptive, which is much, much higher potency than the estrogen in HRT. However, there are a few considerations to be made. So we do know that, particularly with estrogen oral contraceptive, people with migraine with aura, that's a contraindication. And so in HHT patients with lung AVMs, we know that migraine with aura seems to be associated with lung AVMs. And so in someone with a migraine with aura and untreated lung AVMs, I would probably not go to oral estrogen because of the potential increased risk of worsening migraines and increasing risk of stroke. And so that's where the transdermal or patch estrogen may be preferred. And then along the same lines for a blood clotting risk, we know that from the CHORUS registry, the blood clotting event rate in HHT patients is about 7%. So that's about 3 to 5-fold greater than in the general population. And so we know that oral estrogen can also increase the risk of blood clots about 2-fold as well. So this is not to say that, HHT patients cannot receive oral estrogen. It's only something to consider in the decision making, especially if there's additional blood clotting risk factors that could be additive. And so in that case, then, if there is concern for a higher risk of blood clots because of all these various risk factors, then the transdermal or patch estrogen would be preferred. So the last slide just shows, the different phases across a woman's lifespan, the different hormonal therapy options, and then what are potential risks and adverse effects. And I'm not going to go through each of these, but I think just some things to consider in the premenopausal phase. The things to consider are the need for contraception, what are the pregnancy goals, and then typically would want to avoid, oral estrogen in those with migraine with aura, smoking, or high blood clot risk. And then in the perimenopausal phase, things to consider are bleeding pattern. A lot of times there can be more irregular, heavier bleeding as we transition to menopause. And so which of these hormonal therapies might be more effective for that? Also, perimenopausal symptoms start to emerge as well. And then in the postmenopausal phase, history of clots, stroke, cancer, all medical conditions come into play into the decision about HRT and which formulation and route would be most appropriate. So in conclusion, women with HHT face unique challenges across the lifespan, and there remains significant gaps in knowledge in women's specific conditions. And so that's why it's critical to have these discussions, to have multidisciplinary collaborations, to have initiatives such as the Women's Health Initiative by Cure HHT to really advance our knowledge, care, and improve outcomes. And that was it. Thank you. I'll take questions.
Thank you, Dr. Dow. That was very informative, and I'm glad we were able to record this. A lot of great information for everyone. I'm going to ask you a couple of questions that our patients sent us. We talked about pregnancy and the different options for childbirth. Patients are asking, do they need to see a high-risk OB for their pregnancy care? That's a twofold question. Do they need a high-risk OB? And do they need a high-risk OB if there's no AVMs?
Yeah, I am. That's a great question. I think most OBs would consider a patient with HHT as high risk, simply because there is increased risk for potential complications than a quote unquote typical pregnancy. But of course, within that risk, there's risk stratification. And so we know that, from the studies that I mentioned, the risk of serious pregnancy complications is pretty low in HHT women. And it's mostly in women who are unscreened or have untreated lung AVM. So it's really for women who have that where they should definitely be seen and cared for throughout pregnancy at a specialized HHT center. And in terms of, women who don't have any of those risk factors, then I think, if that's available to be seen at a HHT center, that's always preferred, of course. But if not, then I think they could be followed by their high-risk OB, at their general practice or our institution.
So I'm going to pivot a little bit. We had a couple of other questions, some general questions. Another hot topic is the GLP-1s. And people are asking, are they safe for women with HHT to use a GLP-1 or GLP-1?
Yeah, so that's a great question. Of course, with increasing use of GLP-1s, I think, there really is no data in this. To my knowledge, there's really no data that suggests or any, you know, serious concerns that GLP-1s could worsen bleeding in HHT. So there's no contraindications about GLP-1 use in HHT patients, but of course, with more use, long-term data on GLP-1s, there might be more to discover, but as of now, there's no clear issues.
Thank you. I know we talked a lot about menstrual bleeding and measurement, but that's always a question that comes up quite often. And one of our participants asked, what is the menstrual bleeding threshold at which HHT patients should consider prophylactic treatment rather than on-demand treatment?
Yeah, I think that kind of alludes to the slide about how we diagnose heavy menstrual bleeding, and really there's not a perfect way, and that's an area of ongoing research is how to better improve heavy menstrual bleeding before it gets to the stage of causing iron deficiency anemia. So we want to catch it earlier, but essentially, I think if a woman has menstrual blood loss that's significantly affecting any part of their quality of life, and it's causing iron deficiency, then there should be early discussions about some type of treatment for that, whether that be hormonal therapy and or non-hormonal therapy. And so I think we use a combination of clinical symptoms, sometimes laboratory symptoms. And that's why it's helpful to have these multidisciplinary clinics with hematology and gynecology, so we can have those discussions and evaluation for heavy or irregular menstrual bleeding earlier on.
Can you speak a little bit about, so most women are familiar with a lot of menopause symptoms, the hot flashes, the brain fog, and so forth. And patients are asking, are any of those menopausal symptoms, are they accelerated by HHT or is it generally the same?
Yeah, that's a really great question too. I think, I don't know of any direct worsening of symptoms directly from HHT, but there is a lot of overlapping symptoms from HHT that can overlap with menopausal symptoms, you know, namely symptoms from iron deficiency anemia, which is highly prevalent in HHT women, causing fatigue, brain fog, insomnia. So all of these are overlapping symptoms with also, postmenopausal symptoms. And so certainly in women with HHT, those symptoms could be intensified because of their underlying HHT as well. So for that reason, I think it's important to optimize as much as we can from an HHT standpoint, so that any postmenopausal symptoms are not exacerbated.
I have another general question. I know you talked a little bit about uterine AVMs, and we talk about the screening for the lungs and the brain and so forth. So some of the patients are asking, are uterine AVMs something that should be screened for in women? And if so, how often and what age?
Yeah, I think that's really unknown, but I do favor, if a woman with HHT has heavy menstrual bleeding, I typically follow the gynecology society evaluation of looking at structural and non-structural causes. So since uterine AVMs seem to be really well picked up with pelvic ultrasounds, and that's something that is already done to screen for, other structural issues that could cause heavy menstrual bleeding, I do favor, earlier screening in women who do have heavy menstrual bleeding. The frequency or interval of screening is really unknown. And I think that's why we have to have these women's health initiative studies to first determine what is the incidence of uterine AVMs in HHT women, how are they associated with heavy menstrual bleeding, and what is the optimal, frequency of screening. What would be the optimal time to start screening? Right now, so much is unknown, but I would screen someone with a pelvic ultrasound with Doppler, if they're presenting with heavy menstrual bleeding, to evaluate for that, and also other structural causes too.
To pregnancy again, just we have time for maybe one more question. So we had some participants asking, is the risk of miscarriage in HHT patients greater or is the same as non-HHT patients?
Yeah, so I think from the studies that have reported on this, it seems to be the same as in non-HHT patients, which is around 20% or so. So there doesn't seem to be a clear signal yet that we know of that there is an increased risk of miscarriage in HHT.
Well, thank you so much for everything this evening. We really appreciate it and your time. And we thank all of our patients who attended this evening. You will be getting a link to the recording, and we hope you'll join us for more webinars and events during Awareness Month, which is coming up in just a few days. So thank you so much. And we hope you all have a good evening. Thank you, Dr. Dow. We really appreciate
Yeah,
it.
thank you so much. And thank you all
Thank
for
you.
joining.
Good night.
Bye.